Hey everyone, it's Buck Joffrey here for Sapio Podcast, and today we're going to do an interview with somebody who's going to go into quite a bit of depth on the topic of lipids. This is a really, really important topic, and hopefully you will get something out of it. It does go into quite a bit of depth, though, and try to take some notes and hold on to the key points that I try to highlight throughout. Let me take this chance also just again to remind you that I have a course now. It's called Longevity Roadmap. You can check it out at longevityroadmap.com. It's perfect for you if you are interested in this stuff and want to take it sort of to the next level. Make sure that you have the core foundation of all the things that we know about clinical longevity and the science of longevity, and ultimately how to apply those things to yourself. The one thing I want to point out too is anybody who signs up this week will also get one-on-one coaching with me for the rest of the year. Why is that? Well, the community right now, since we just launched, is very small. So it's not as self-perpetuating as it will be eventually. So I want to make sure you maximize the value of what you're actually getting. By working with you one-on-one, I can make sure that that happens. So anyway, check it out, longevityroadmap.com. And here is a podcast for the week.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. This is Buck Joffrey, and today my guest is Dennis Hughes. So Dennis is a physician here in Montecito. He's a concierge physician. He has a medical degree from the medical school at Robert Wood Johnson's UMDNJ in Newark. And he completed his internal medicine residency at my medical school alma mater, which is Northwestern Memorial Hospital, and has worked in various different practice situations before coming to town here in Montecito. Dennis, thanks for joining me.
Thank you for having me.
So yeah, I went to Northwestern University Medical School actually myself. So you were there. Looks like you were probably there. Well, actually, I think we overlapped a little bit. Yeah. Well, I mean, I was a medical student, and in between 1997 and whenever that was, I took a year for research there, so I was there probably until about 2001 or so. So you were there when we got the new hospital and all that stuff, right?
I was the resident on call when we moved all the patients from the old hospital to the new hospital.
Oh, is that right?
Yes.
Lucky you.
Pretty shaky day, but nothing happened.
No, so this was just so for reference, people, this is a phenomenal hospital, Northwestern Memorial Hospital, and the one that they built. I was going to say the new one, but at this point it's not new because it's like 20 something years old. But one of the things I remember though is, didn't they forget to put in the call rooms? Wasn't that one of the issues?
No, we had call rooms. They were tiny bunk beds. But...
I think that was a construction flaw though, because I think initially they forgot about them and then they went back and retrofitted, and that's why they were so tiny. Anyway, it is what it is. Well, listen, it was good. It's good having you, and I know you're so you're local, and you have obviously a lot of interest in internal medicine issues in general, but I understand that you have a special interest in the field of lipids, and so I thought it'd be a good conversation to have. So how'd you get the special interest in lipids anyway?
Pure chance. I went to one of those pharmaceutical dinners,
Yeah,
and the speaker was Dr. Thomas Dayspring, who's a nationally renowned lipidologist. And the first thing he said when he got in front of us was, "You guys don't know what you're doing."
yeah.
In New Jersey style. And he was correct. So he went through his slides, and I thought this stuff I'd never seen before, because I don't know how it is now, but when I was in my training, lipidology training was pretty bare bones.
Yeah.
And I was interested in that. And so I went to another talk with Dr. Robert Sapirko and another with Dr. Terry Moran, all lipidologists. And I bought a book on lipidology, and I just did some self-study.
Mm-hmm. So, okay, so bare bones stuff. Well, I'll tell you what I learned in medical school. Obviously, it's it's not even close to what we talk about these days, but we learned, there was LDL was bad cholesterol, HDL was good cholesterol.
Makes me crazy.
Yeah. And that was pretty much it, right? I mean, obviously you had you're concerned about your triglycerides as well. So tell us how you're supposed to look at it. How should you look at it?
Well, the way I speak to patients is I tell them that my term for this is dyslipidemia, because I think the problems are more nuanced than just saying high cholesterol or low cholesterol, at least in 2024. So I say to patients that cholesterol is necessary for life. It makes up a large part of our cell membranes. It's important for making steroid hormones like testosterone or estrogen, cortisol, and more. And that any cell in the body can make its own cholesterol. That cholesterol is transported along with other things like triglycerides and phospholipids, which phospholipids also make up part of the cell wall. They have to be transported inside of water-soluble carriers called lipoproteins, because these substances, cholesterol, phospholipids, and triglycerides, are lipids, which are organic oil-soluble molecules that just won't dissolve in blood.
Right.
So this is called lipid transport. And, it's pretty interesting the way the system works. At any given time, your body is trying to maintain homeostasis of cholesterol. That means keeping cholesterol in balance. You would not be alive this moment if you didn't produce and absorb cholesterol. But at the same time, if you don't get rid of the excess, cholesterol can crystallize inside the cell and make the cell dysfunctional or die. And so your body has this system designed to maintain this homeostasis called lipid transport, so that at any given time, any cell in your body is producing its own cholesterol. Your small intestine is absorbing cholesterol, and maybe through something called the ATP binding cassette is effluxing the cholesterol back out into the intestine. Your liver is producing cholesterol, and at the same time, these lipoproteins, which are filled with cholesterol, are binding to your liver, and your liver may take that cholesterol back and secrete it into the digestive tract through bile, or your liver may pass it back out into the bloodstream again for another run. All these things are happening at the same time.
Yep. So I've talked quite a bit on this show about, not necessarily looking at LDL cholesterol per se, but more looking at apolipoprotein B, for example, in terms of, because it sort of encompasses not only LDL, but it also encompasses intermediates and triglycerides and any number of other things. So when you're looking at people's labs, what are you looking at to determine if there is the issue? Like, what's the proper way to look at a set of labs? What do you order? And I guess what's your sort of way to look at it?
Well, as you know, there are a whole lot of labs you could order. Right. I order the ones that give me the most ability to make good decisions going forward. And that would be a standard lipid panel, which is LDL cholesterol, HDL cholesterol, triglycerides, VLDL cholesterol. But I also do apolipoprotein B and lipoprotein little a.
Right.
And I just got down here, but I want to start at least one time meeting a new patient, ordering their phytosterol absorption panel, which is basically plant cholesterol. We don't absorb that very well, but some people do, and it's very atherogenic, meaning that it has a high capacity to cause artery disease. So I think at least just one time, I think it's worth to order that panel.
Yeah. By the way, that one also, I think the commercial one is, I think there's one that's commonly the Boston cholesterol. Is that the name of it?
Boston Heart Lab.
Yeah, the Boston Heart Lab. But I think I've talked about that on the show quite a bit, and really what that's, and what's interesting about that is, I grew up and through training, I had learned that, or I had at least assumed that a lot of our cholesterol was from our diet, and that we could, decrease our cholesterol levels or our quote unquote bad cholesterol by eating less cholesterol. But as it turns out, majority of people don't really absorb much cholesterol, and it's about 30%, I believe. You correct me if I'm wrong. That actually do tend to absorb material amounts of cholesterol in their diet. Is that right?
Maybe even less. And then there's also something called the ATP binding cassette G5, G8. That's the bouncer. So although you may absorb some from the small intestine, you may efflux it right back into the intestine lumen. And that's what we do most of the time with phytosterols, those plant cholesterols. The body doesn't want them. And so that this ATP binding cassette is there to remove it out of the body.
Okay, so you get these tests, and what are you focused on? Let's kind of break them down. We talked a little bit about apolipoprotein B already. I mean, I'm assuming, from the big picture, that's the one apart from AP little a, which we'll talk about in a second, that's the one that you're really kind of starting with, right? Where's your ApoB at?
That for me is the most important measurement. Right. So I'll start with saying there's no such thing as good and bad cholesterol. You know this.
Right.
Cholesterol is carried within lipoproteins. Those are the little FedEx vans that transport cholesterol throughout your bloodstream. And so this notion of good and bad cholesterol, there is only one kind of cholesterol, and it's called cholesterol. But the three lipoproteins that are atherogenic are VLDL and LDL and lipoprotein A, little a. Those, when they get into the artery wall, get stuck. And when they do, if they become oxidized by reactive oxygen species, this cycle of inflammation and vessel destruction begins. So I like to see how much cholesterol is carried within VLDL and LDL. And if you have lipoprotein little a, some people don't.
Most people wouldn't have lipoprotein little a to any sort of to significant amount of it, though, right? I mean, otherwise.
It varies from person to person. Anecdotally, I see, so our goal is at least less than 50, and I see a spread. Some people are borderline, they may have 50, but sometimes I see people with 150 or 250. And so I like to know how much cholesterol is being carried within the lipoproteins, but more importantly, and this is a function of living in modern society, I want to know how many of those cholesterol carrier particles you have, because that is directly correlated with atherosclerosis. And those three atherogenic lipoproteins, VLDL, LDL, and lipoprotein little a, all have something in common. They carry one molecule of apolipoprotein B. Apolipoprotein B is the key that goes into the lock. It is what interacts with the liver receptor, so that when these lipoproteins tumble into the liver lining, the apolipoprotein B interacts with the LDL receptor, and the parts are internalized to the liver and either sent down the intestine out to the toilet, or can be sent back out to the bloodstream for another go. And so it's a great test, apolipoprotein B, in that it's inexpensive, it comes back quickly, but it's also very telling. I think that we've always had need for cholesterol, but modern living has caused a disruption in the handling of cholesterol in terms of obesity, insulin resistance, sedentary lifestyle.
When you get the standard lipid test, I mean, if we're really focusing on ApoB, what should you be looking at in terms of LDL, HDL? I mean, what's the role of HDL at all at this point?
So HDL has multiple different functions. HDL can remove cholesterol from the artery wall. So the atherogenic lipoproteins like VLDL, LDL, and lipoprotein a can't easily flow into the artery lining and then back out, but HDL can. And so when HDL flows into the artery lining, it can bind to a type of white blood cell which has imbibed cholesterol. This is called a macrophage. And through ATP binding cassette, the macrophage can pass the cholesterol into the HDL, and the HDL can return to the liver and pass the cholesterol into the liver, in which case, again, the cholesterol can be secreted into bile and through the digestive tract, or it can be passed back out into the bloodstream. HDL can also bounce into LDL and transfer cholesterol into the LDL.
So one of the things that's I always found kind of interesting, though, is that, again, listening to you talk, I mean, HDL has some positive benefits, but in reality, any drugs that's ever been used to raise HDL really has not created a whole lot of benefit.
Correct. But I think this is a misunderstanding. We're into the notion of association versus causality. So the most common cause of a low HDL cholesterol is living in a modern country where we have overnutrition, obesity, and insulin resistance, all of which is a risk factor for atherosclerosis. So I don't believe that low HDL cholesterol causes atherosclerosis. It's the underlying obesity, insulin resistance that does. So
it's not causal. It's something you're seeing sort of downstream as a result of that.
You're just seeing an association. Both things are happening at the same time. Yes, you have low HDL cholesterol at the same time that you tend to have a higher risk of atherosclerosis, but that doesn't mean A causes B. It's the underlying insulin resistance that causes low HDL cholesterol, but also causes increased ApoB. How does that happen? When you have insulin resistance, you increase the activity of an enzyme called CETP, cholesterol ester transferase protein. That causes HDL to pass its cholesterol to the VLDL. The HDL becomes smaller and smaller. And when it passes through the kidney can't hold on to it. This tiny HDL particle is excreted in the urine, and your HDL particle count, the number of the lipoprotein named HDL, drops. You don't want that. And you might think, actually, if the HDL was doing its job, binding to the macrophage in the artery wall, and then dumping that cholesterol in the liver, that the HDL cholesterol should be low. People have this idea that if you have a large HDL cholesterol, that's great, because people assume that means HDL is swallowing up all the cholesterol out of your artery wall and getting bigger and full of cholesterol. This is not true. Actually, a really high HDL cholesterol can suggest HDL dysfunction. So when you look at these lipoproteins binding to the liver, and these lipoproteins have proteins on the surface called apolipoproteins. Apo just means on top, so they're proteins on top of the lipoprotein. There is an apolipoprotein called ApoE, which binds very strongly to the liver receptor. Some people have HDLs with an ApoB on top, and that way the HDLs can easily delipidate or pass the cholesterol into the liver. But if you don't have that, you might not be able to pass the cholesterol into the liver, and your HDLs are just bloated with cholesterol, dysfunctional.
What's interesting about that is that there's still a lot of people out there who talk about, I hear that, I mean, like literally hear them these days talking about that they don't care when LDL levels are elevated. They're more interested in the ratios between LDL and HDL. And that seems to me to be quite wrong. That you should be concerned about elevated LDLs regardless of the status of HDL. Is that, what do you think?
You mean LDL particle count?
Yeah. Yeah. Well, I mean, people talk about LDL versus HDL in terms of, the labs.
Oh, the cholesterol ratio.
Yeah.
Okay.
Cholesterol ratios. I mean,
I believe that ratio is a surrogate marker for either LDL particle count or apolipoprotein B, basically counting those atherogenic particles. So I think that the factor most associated in research with atherogenesis is apolipoprotein B,
right.
because you're really counting the number of atherogenic particles. To me, it's two things. First of all, those atherogenic particles, VLDL, LDL, and lipoprotein a, can more easily pass into the artery lining in an artery lining that has been damaged. Inflammation, cigarette smoking, high blood pressure, type 2 diabetes. So that's one thing. But also that I talked about CETP a moment ago in the setting of insulin resistance. So what happens with insulin resistance is not only do you lose your HDL particles through the urine, but also there is a change in the distribution of LDL particles in insulin resistance. So when you have a type 2 diabetic who's insulin resistant, what happens is the LDL particles, the lipoproteins, they become more numerous, dense, and smaller. And you might think, oh, they're smaller so they can get into the artery lining more easily. That's not really it. It's just the fact, current thinking, that because they're more numerous, it's physics. It's called gradient pressure. There's just more LDL particles knocking on the door of the artery, just trying to pass in. Yeah. And that, I believe, is why insulin resistance and type 2 diabetes mellitus cause more atherogenesis. It's that change in distribution of the LDL particles into the smaller, denser, more numerous distribution.
I get a few different questions here. One is, what are your target numbers for ApoB specifically?
That's a great question. So I think it kind of depends on the patient. I have a talk with my patients and I'll say, okay, there's two boxes here. There's good and there's optimal. And I always want to look out for patients and keep their arteries healthy. And for me, that means shooting for optimal. I'm sure you know this. When you are young, the process of coronary atherosclerosis starts at that age in your 20s and 30s. And we know that from autopsy studies.
Or even younger.
Even younger. Yeah, that's true. But the autopsy studies done on those people who died from homicide or accident will show this. And by the time you have a heart attack at age 60, it's been creeping for decades. And I think people not having any symptoms at all during all those years, they say to me oftentimes, but I feel fine. And there's a disconnect there. And I'll say, yeah, of course you feel fine until then you have a myocardial infarction, a heart attack.
And just to emphasize that point, 50% of the people that present to the health system with coronary artery disease present dead. So that's probably a pretty good reason not to just say, I feel fine and I don't have a problem.
Right. I try to talk my younger people with dyslipidemia into, aside from lifestyle factors, which is very important, regular and vigorous exercise, proper diet, low carb, high protein. But if they've got dyslipidemia, I try to talk them into pharmacotherapy because that's really the only knob I can turn to improve their vascular health and try to avoid problems down the line. That can be really challenging because oftentimes young people just don't want to take medicine. I get it.
Well, what number do you target that though? I mean, like when you look at them, I mean, obviously it depends on maybe how old they are and so on and so forth. But I mean, I've talked to, cardiologists who, a few different cardiologists now that are pretty aggressive on this and want those ApoB numbers to be 60 or below.
That's what my target is. Yeah. I want my LDL cholesterol and apolipoprotein B 60 or below. I had heard of a study that showed plaque regression, plaque regression, not the hard and matured calcified plaque, but soft plaque can regress when you get your numbers there. I did a coronary artery calcium scan on one of my patients, and it was pretty high. He's 59. And I got his LDL cholesterol down to 23 with combination therapy and his apolipoprotein B down to 43. That's where I want it.
Yeah. Yeah, no, it's interesting because I actually have another friend, other physician friend, who actually was referred for a bypass, and for whatever reason, he decided he was just going on Repatha and artificially decrease his lipids to the point where, there was some regression of plaque, and then he got a follow up angio, and he didn't need the bypass anymore. So I'm not
That's
recommending
awesome.
that for people in general. Like this is not medical advice, but it just goes to show there's something there. That's anecdotal indeed, but I've heard cardiologists talk about this quite a bit, and the plaques that are the dangerous plaques are the soft plaques. So that's what if these things are actually regressing the soft plaques, that's pretty exciting information.
True.
Right.
Those soft, large plaques, which have a thin cap, are in danger of rupturing. And so when that plaque ruptures, the platelets, which form clots, can't tell the difference between you cut yourself shaving and you ruptured a plaque, and they look to seal off what they think is a wound. And that's what blocks the blood flow and causes a heart attack or stroke. I think one of the things that gets to me is that when a patient goes for a cardiac stress test, if the stress test is normal, they're often told, looks clean, looks good, and they go home thinking no problem. But you and I both know that in order for the stress test to be abnormal, you have to have a 70% obstruction
Yep.
with plaque in the lumen, the interior of your vessel. So you could have a 30% obstruction with soft plaque that's vulnerable to rupturing. That's not going to show on the stress test. That's why I do imaging.
Yeah. I mean, this is one of the problems. I think that, I think the way we as physicians have been taught about this is all wrong, and it's hard to go back and teach an entire generation of physicians how to think about this. But it's
True.
this is not a problem to play defense with. It's a problem that, as you alluded to before, I mean, you look at autopsy studies. You've got like teenagers with plaque formation, the start of plaques, and so this is a very long brewing disease, which if you can intervene in early enough, this cardiovascular disease really should not be the number one cause of death.
Not in 2024. I like what you said about relearning. I think
Right.
there's some resistance to that.
Oh, a ton. Yeah.
I kind of understand it in a way because, we all spent a lot of time and effort learning things, and we're holding on to those things we were taught. And it takes a lot of effort to turn around and relearn that. But we build upon our knowledge over time. This is natural, whether you're a scientist or a physician. Some of the stuff we believed 15 years ago has changed.
How do you, so one before I get into pharmacotherapy, I want to talk about A real quick, because I think this is one of these really underappreciated tests that probably very few internists are actually ordering that test. Talk a little bit about A and why that's important, the genetic nature of that.
So, lipoprotein a carries the apolipoprotein called Apo. And this is particularly atherogenic. It has a higher chance of causing artery disease than LDL. And why is this? The current theory is a couple of things. First of all, what is Lp for? It's thought to be a scavenger for oxidized lipids. And so it may grab some of that from your artery or somewhere else and dump it into the liver, hopefully, where it's secreted out of your body. But the problem is that this Apo is bound by a bridge to apolipoprotein B. So I had said earlier that apolipoprotein B is one of the keys that fits into the lock at the liver lining. The lock is the liver receptor, and ApoB is the key that fits into it so that the lipoprotein can be pulled back inside. It's thought that the apolipoprotein A sitting next to the ApoB is somehow blocking or reducing the binding of lipoprotein A to the liver, so it cannot delipidate. So what happens? These particles are floating around, tumbling through the bloodstream, hopefully getting back to the liver at some point, but ending up in the artery wall along the way. And these oxidized phospholipids set up that chain of chronic inflammation and vessel destruction. These lipoproteins, I used to think years ago, because that was my training, that cholesterol was produced in the liver and it was delivered by these lipoproteins to various tissues. But it turns out, interestingly, that any cell can make its own cholesterol, maybe in terms of stress. For example, if you need more cortisol because you're going through some stressful illness, you may need to deliver some more cholesterol to steroid-producing tissues like the adrenal glands to make more cortisol. But in general, our cells can make their own cholesterol. Why does the liver pack cholesterol into the lipoproteins in the first place? Well, what are the lipoproteins really for? Current thinking is that the lipoproteins deliver phospholipids to tissues so that they can develop their cell membrane, but also triglycerides to target tissues, which use triglycerides for fuel and energy storage in adipose tissues. The cholesterol packed into the lipoprotein lets the lipoprotein assume a spherical shape, which makes more volume so you can pack more phospholipids and triglycerides into that lipoprotein.
Right.
So the tricky thing about lipoprotein little a, which is present in about 20% of people. So to your point, that's why it's worthwhile to test, because a lot of us have it. There's no really good treatments to lower lipoprotein little a. Repatha may lower it by around 20-25% if you're lucky. Anecdotally, I've seen it do nothing or lower it a bit.
So one of the things that's tricky about it now, so you could, in theory, be looking at pretty attractive, HDL, LDL, all the typical stuff that people are ordering, but you could end up being somebody who has a high level of apolipoprotein little a. That basically could trigger a lot more atherogenic activity than you would think with the rest of your lab profile, right?
Absolutely. So that's why it's really important to know if it's there or not.
Right. And you got to test for it. Like basically, if you test for it once in your life, you're kind of done, right? I mean, if you don't have to, because it's a genetic thing. So I encourage people to have their physicians look at apolipoprotein little a at least once if you've never had that ordered, because if it's not elevated, you don't need to do it again.
Right. If it's elevated, it's been elevated your whole life. I just did a yearly physical on a patient of mine. She's 35. Her lipoprotein little a level was 258.
Okay.
Banging high.
Yeah. Yeah.
We have, hopefully, some new medicines on the horizon for lipoprotein little a lowering called antisense oligonucleotides.
Yes.
And one of them in research drops it by 99%. If all goes well, the prediction is maybe 2026. They're still in study, so let's see if they get approved. I'm sure they'll be very expensive, and there'll probably be strict cutoffs from insurance companies. But my understanding, listening to the lipidologist, is that until those medicines come out, at least get your apolipoprotein B as low as you can. Get your LDL cholesterol as low as you can. And that may offset to some degree an elevated lipoprotein little a. And I'm wondering why that would be so. I have a guess, but it's just me spitballing.
Yeah, I'm guessing it probably has to do more with eliminating some of the other risk that's there, and letting little a kind of do what it does, but it doesn't have the additional damage of any other elevated ApoBs. And probably, if we talked about before that if you have an ApoB that's below 60, and if it's actually, reversing some of these plaques, that probably is helping with that a little bit as well. So,
yeah, I wonder if you optimize your other lipid elements, there's less competition for binding to the liver LDL receptor. We talked about how the lipoprotein little a has a tough time. It binds very weakly to the liver LDL receptor.
Mm-hmm.
Maybe there's just less competition, but
yeah,
I don't have any evidence for that.
Let's talk a little bit about pharmacotherapy. I mean, I presume your first line is going to be statins here. Is that right?
So in order to get to my targets, the apolipoprotein B and LDL cholesterol below 60, I usually use combination therapy. I use a statin, usually a hydrophilic statin. So hydrophilic means it is more water soluble, and that statin is rosuvastatin.
And is
I
that
use
because you don't want to go through the blood-brain barrier?
It's mainly because it has a lower chance of causing muscle aches and weakness. So pravastatin and rosuvastatin are hydrophilic statins. So they have a lower chance of causing grief in terms of side effects. But rosuvastatin is also very potent. And I combine it with ezetimibe, which binds to the Niemann-Pick protein in the small intestine and reduces how much cholesterol you absorb from the gut. Interesting thing that happens is when you use a statin to lower the pool of cholesterol in your liver and to increase the number of LDL receptors on the surface of the liver, your body somehow senses that you're producing less cholesterol. So it opens up that channel in the small intestine and tries to let more in through the gut.
Is that
When you
right?
use those-
So that's not just that's interesting. I didn't know that. So you're saying that if you actually decrease production, you'll increase absorption?
Yeah, your body's
Wow.
trying to do
Okay.
a workaround. It's trying to sneak
Uh-huh.
more in through the back. And so when you use those together, two inexpensive medications, and I use a small dose of rosuvastatin, I think when doctors continue to double the dose of the statin, you're not lowering the cholesterol that much more and the ApoB as well. You're just increasing the likelihood of side effects. So I like combination.
I was under the impression, and it's interesting that you mentioned that because I was under the impression that the whole reason for the Boston heart cholesterol tests and stuff was to determine whether you'd be a better responder to a ezetimibe type thing or a statin. But you're saying that actually that's whether you're absorber or you are a producer is sort of dynamic. It's not it's not always the same.
Yeah, we're all different in how we deal with cholesterol.
Yeah.
Most of us are overproducers. A minority of us are overabsorbers. But I don't think those issues are mutually exclusive. I like to use combination therapy because it amplifies my apolipoprotein B and LDL cholesterol lowering when I add ezetimibe or Zetia to the statin. But to your point, a minority of people do overabsorb phytosterols, and for those people, the ezetimibe works very well.
What is can you are you able to get people's ApoB down below 60 without using like something harder like a Repatha?
Well, the combination therapy of the statin and ezetimibe, in my patient I just spoke about, I got his ApoB down to 43.
Wow. Okay.
Those numbers stick in my head because they're fresh. I just went over them with him. He was pleased. Funny thing, so his wife has dyslipidemia as well. And while her husband, the patient I just spoke about, he accepted therapy because he had a very high coronary artery calcium score. And that's one of my tricks to get people to accept taking medication, because I think I can sit here and tell an asymptomatic patient, look, your numbers are awful and I'm worried about you. And whatever happens to your coronary arteries is also going to happen to the arteries in your brain, which can lead to cognitive deficits, dementia down the line. A lot of people aren't willing to accept it because they have no symptoms. But when I show them that coronary artery calcium scan score, they're on board. They're ready to go. So when my patient's wife saw his scan, she just emailed me and said, I'm ready to do the medicine.
Yeah. What do you do with, I'm sure you've had these situations where maybe you have a patient who has a higher risk of Alzheimer's disease, maybe has an ApoE4 allele. Do you get concerned at all about prescribing statins in those situations?
I don't, because the research doesn't speak in favor that it causes dementia. And as a matter of fact, they may reduce the dementia risk. The problem is that, studies cost a lot of money, and studies are always way too short. I want to see studies done over 10 to 20 years, 30 years. But you know, most people are doing studies anywhere from 6 months to, if you're lucky, 5 years. And so are we always powered to show what we want to see? I don't think so.
Yeah. Yeah, that makes sense. Um, what, I mean, I could ask you a lot more questions. I've already taken about 40 minutes of your time here, but, what do you recommend that people out there do? Like, if they feel like, gosh, this conversation is complicated, but I know my doctor's not doing much of any of this. What do they do? I mean, that's like goes back to our education question, but when you're a patient, that's a tricky thing. Like, I mean, you can't tell your doctor what to do.
Right. There's an awkwardness there. I
Yeah.
mean, they can ask,
Yeah.
hey, I've been doing some reading about apolipoprotein B or lipoprotein little a, and they're going to get one or two answers. The doctor may say, you know what, that's interesting. Let's do that. I'm going to look into that. Or they may say, oh, that's nothing.
Yeah. And if they say it's nothing, they might need a new doctor. I mean, frankly, that's just the reality. And I heard Dr. Dennis Hughes is taking new patients. so
Thank you for that. You brought up Repatha. I just wanted to touch on that.
Yeah, sure.
So how does Repatha work? So statins increase the number of LDL receptors on the liver that would clear those atherogenic particles out of the bloodstream and back into the liver, and maybe even out through your digestive tract to the toilet. So Repatha, or Praluent, PCSK9 inhibitors, they work by also increasing the number of LDL receptors on the liver. But they do it through a different mechanism, and they do it very powerfully. I was speaking to Dr. Duncan Turner recently, and I told him about a patient I had, and I don't know if it was a typo or not, but this patient was on Repatha, and his LDL cholesterol was 4. I never saw that before. They're pretty powerful.
Is there any downside to having a LDL cholesterol of 4?
Tough to say for certain, but I don't think so, for a couple of reasons. First of all, any cell in the body can make its own cholesterol. During periods of stress, you may need to make some more, but there are some people who don't make much cholesterol at all.
Right.
It's called hereditary hypo-beta-lipoproteinemia. It's a big mouthful of a word, but it just means your LDL cholesterol level might be 20, 30, super low, and they don't seem to suffer because of it. So when I talk to patients, I reference that, those two things, that your tissues make their own and that people who can't make enough seem to be okay. And I just wanted to touch on one more thing. When we look at, for example, LDL cholesterol, we're just looking at the amount of cholesterol within the lipoprotein carriers in your bloodstream. We're not looking at how much cholesterol is in your total body or within your cells. So it's almost like vitamin D. I don't know if you've noticed this, but people who are obese often have a low blood level of vitamin D. Why is that? Because vitamin D disperses into adipose tissue, fat cells. And so in those people who may have a normal total body vitamin D, their blood level is low and it's not really telling. So you have more cholesterol on the membranes of your red blood cells than you do in all the lipoproteins. So we do the best we can measuring these things, and they are correlated with clinical outcomes. But it's a little tricky, but I don't think I'm hurting somebody getting their numbers down.
No, I don't think you're hurting getting people's numbers, and especially when you talk about LDL or ApoB. When you're talking about ApoB, and I mean, children are running around, what, 20, 30. So, I mean, they're fine. I was curious more about when you're talking about 4, I mean, at that point, I've never heard of 4, so I don't know if that's.
I haven't either. I don't know if it was a typo or not.
Right.
He was on Repatha. So, Repatha is a great drug, injected once every 2 weeks. It's being approved more easily in those people who have really sky-high apolipoprotein B and LDL cholesterol, people with familial hypercholesterolemia.
Yeah, I guess so. I guess the question on that too is with statins, how often are you getting myalgia symptoms? One thing that I did see was there was some study showing some fairly significant mitochondrial dysfunction in patients on statins. And obviously when you have myalgias, you can correct some of that with CoQ10. And, that goes to the theory of, mitochondrial dysfunction, obviously. But how often are you seeing that? And, what's your trigger for Repatha?
I don't know exactly. The word on the street is 15% of people get myalgia on statins. And some of that's going to be dose dependent and individual susceptibility. Certain statins, like simvastatin, are very prone to causing myalgia and muscle weakness, and that's a fat-soluble statin. I tend to avoid those. If somebody has myalgia and or muscle weakness on statin therapy, I may lower the dose. I may change to a different statin. So pitavastatin, which is Livalo, is now generic. And I've never seen anybody have muscle symptoms because of it. And part of that might be because it's been so expensive for so many years. I haven't been able to prescribe it as much as I would have liked to. But I have been prescribing it quite a bit lately now that it's cheaper and more available. And I just don't get anybody emailing me saying, hey, this is a problem.
Yeah. Good stuff. Dennis, I appreciate you being on the show. And looking forward to running into you in town. We'll talk a little bit more about the stuff.
Are you in town?
I am. I live in Montecito.
Great. Yeah. I'd love to meet up with you in person sometime.
Fantastic. Thanks, Dennis.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.